Occupational therapy is intended to enhance a person's ability to perform basic self-care activities, useful work and leisure activities. Even simple tasks require the coordination of many abilities, the ability to feed and move sufficiently, sensoromotor ability, the ability to create and execute a plan, cognitive ability, and the ability to want to do the task and to persevere until it is completed, that is, psychologic ability. Recovery from spinal cord injury depends on the location and degree of damage. The higher up the level of injury, the greater the physical impairment. Injury at the level of the chest or below usually involves weakness or paralysis of the legs, paraplegial injury. Injury at the level of the neck usually involves weakness or paralysis of all four limbs, quadriplegia. If the level of the of injury is very high in the neck, the muscles that control breathing may be paralyzed and a ventilator may be needed to assist breathing. If the spinal cord is completely severed or destroyed, the body below that level becomes paralyzed. If the spinal cord is partly severed or damaged, the body below that level becomes spastic. There is little or no skin sensation in the affected area. In almost all cases of spinal cord damage, bowel and bladder control are lost and incontinence comes in. The two most important aspects of caring for people with quadriplegia or paraplegia are preventing bed sores and maintaining joint mobility. To prevent bed sores, the person moves or is turned frequently and a special bed or bedding material is used. When the person is seated in a wheelchair, a special cushion is used. To maintain joint mobility and prevent spasticity, heat, massage, and some medications are used. A paraplegic person can live an independent life. Range of motion and strengthening exercises of the arms and hands enable the paraplegic person to use a wheelchair and to transfer from bed to a wheelchair and from a wheelchair to a toilet or to a car seat. A paraplegic person can be very independent in activities of daily living, and many engage in gainful employment. Some paraplegics are able to drive a car with the help of assistive devices. A paraplegic person can use a motorized wheelchair for independent mobility, but the person must be lifted into the wheelchair manually or mechanically. Some quadriplegics can move their hands or fingers slightly, in which case they can operate the motorized wheelchair with a hand switch. For quadriplegics whose hands and arms are completely motionless, a special device on the motorized wheelchair allows it to be controlled by chin movement or even by the person's breath. But this requires very intensive training. People with quadriplegia generally need support 24 hours a day. Rehabilitation therapy is begun as soon as possible after hip fracture surgery, often within a day. The initial goals of therapy are to maintain the level of strength the person had before the fracture occurred by preventing loss of motion and atrophy of muscle, and to prevent problems that result from bed rest. An additional goal is to restore the person's ability to walk as well as he was able to before the accident occurred. As soon as possible, sometimes within hours of surgery, the person is encouraged to sit in a chair, which reduces the risk of bed sores and blood clots and eases the transition to standing. The person is taught to perform daily exercises to strengthen the trunk and arm muscles, and is sometimes taught exercises to strengthen the large muscles of both legs as well. Usually, within the first day after surgery, the person is encouraged to stand up on the uninjured leg, often with the assistance of another person or while holding onto a chair or a bed rail. While performing these exercises, the person is directed to touch only the tips of toes of the injured leg on the floor. Full weight bearing on the injured leg is often encouraged on the second day after surgery, but depends on the kind of fracture and repair. Ambulation, that is, walking. Exercises are started after 4 to 8 days, as long as the person can bear full weight on the injured leg without discomfort and has sufficient balance. Stair climbing exercises are started soon after walking is resumed. In addition, the person may be taught how to use a cane or other assistive device and how to reduce the risk of falling. Most arm amputations result from accidents. A small number are performed surgically to treat a medical condition, for example, to remove a cancerous tumor. The arm can be amputated below the elbow, above the elbow, or at the shoulder. After amputation, a person is usually fitted for an artificial arm and upper extremity prosthesis. The prosthesis consists of a terminal device. It is a hook or hand, a wrist unit, an elbow unit for an above-the-elbow amputation, and a socket. Movement of the hook or hand is controlled by movement of the shoulder muscles. A hook may be more functional, although most people prefer the appearance of a hand. Control of the above-the-elbow prosthesis as more complicated than that of a below-the-elbow prosthesis. Recently, battery-operated and microcomputer-controlled prostheses have been developed, allowing a person more precisely controlled movements. Rehabilitation after arm amputation includes general conditioning exercises, stretching of the shoulder and elbow, and strengthening of the arm muscles. Endurance exercises may also be necessary. The specific exercise program prescribed depends on whether one or both arms were amputated and whether the amputation was above or below the elbow.
So.
Call it a day. Certainly have an unlimited amount of dictation practice. Timed out material.